Hello, everyone. Welcome back.
Hi.
We had discussed a few topics already: ventilation, gut anomalies, probiotics, even the controversy on that. Hopefully, we'll have more sessions on controversies as breaking updates. Hopefully, we don't want that many controversies happening, but still. In terms of discussion today, we have chosen a very important topic, which is of great interest to both physicians and nurses, and very challenging as well, especially when it comes to the extreme premature baby. So, approach to feeding. What is the right approach? How do we start? How do we progress? What happens if you don't have breast milk? How do we encourage breast milk and so on? Uh, the indication for total parental nutrition, obviously, most of these tiny babies would start on TPN, as we discussed earlier. These babies need the nutrition from day one, if possible, and progress quickly to full strength of TPN. That's a topic for another day, because TPN itself has so many challenges to face and practical points to cover. I know Dr. Thala has made many videos on TPN as well. You can review that as well. But in terms of feeding today, we will discuss, as we said, how do we start, how much do we give, what is trophic feeds, how much to progress, and so on. So, Tala, do you want to start describing how we approach feeding in the, obviously it depends
Yeah,
on the risk factors in the baby and how
right.
quickly we go. Yeah.
So I think here we're really talking about sick term babies or preemies. So really for now, I'll kind of emphasize premature babies. And everybody knows what the issue is. The issue is that during pregnancy, the intestine is really just made or developing to digest and absorb amniotic fluid. It's not ready to start digesting and absorbing milk and being responsible for actually providing nutrition for the infant. So after the baby is born, as everybody knows, the intestine is very immature, and it takes some time to kind of encourage the intestine to develop faster than it would be if the baby was born at 9 months. So we want all those digestive enzymes to start being produced, all the intestinal secretions. We want peristalsis, which is like the squeezing of the intestines and the muscles through the intestine so that the babies, pass everything down and then end up pooping. We want to encourage all of those to get going. And the problem is, though, you're stuck between a rock and a hard place, because basically the only thing that really encourages all those things to start happening is actually delivering small amounts of milk. But the baby, when it's first born, isn't really ready for those small amounts of milk. The other huge two problems that we have is that we know that babies, when you give them good milk, they're going to grow better. It grows the intestine, it gets them ready for the future. But the other side of that is we're all constantly worried that if we advance too rapidly, then maybe we're predisposing them to NEC. So the problem with NEC is when babies were first born early, when we were first taking care of kind of the 30 weekers, maybe the 60s and the 70s, it was quickly realized that if you suddenly increase the feeds on these babies, we're talking going straight to 50 mLs per kilo of feeds, maybe especially formula feeds, these babies did have an increased risk of NEC. So then we all got terrified. Advancing them too quickly is going to increase the risk of NEC. Since that point, we've tried to figure out what speed we can advance feeds at so that babies aren't at increased risk of NEC, but we're still providing them with good nutrition and getting to full feeds and doing the right thing for their guts. And it's been really hard to find exactly what that mLs per kilo per day is to advance by, because it's just a very difficult thing to tease out, especially with NEC being so rare now.
Yeah, it's
So
very
what did you
interesting. Sorry to interrupt. It's very interesting you mentioned about starting point. Have you come across these recent studies? Both in India as well as in other developing countries, where they're starting to feed full feeds from day one of 28 weeks and above, who are reasonably stable. Have you come across these studies?
No, but every single study that I've read has been that it doesn't really matter what you feed, what rate that you feed the babies as long as every single person in the unit is doing the same thing. So this whole standardized advancement is a lot more important than than exactly what we're advancing feeds by. You know, a lot of those studies done in the 70s weren't on the mother's breast milk, though. They were just, you know, formula that being dumped down. So obviously we do know that this is, you know, formula as compared to breast milk is a huge risk factor for neck. And so I don't know if you can put the blame on that. And that's why people feel more confident starting a 28-weeker. It's so hard because, as we always say, we're so terrified about neck, even though it really isn't very conclusive that advancing by 30 mLs per kilo or 40 mLs per kilo versus 15 mLs per kilo is going to make a big difference.
Exactly. I mean, in terms of trophic feeding, it's crucial. I mean, obviously, even if the baby is unwell, there are many questions coming up that the baby is on inotropes, for example. Do we hold feeds fully? A baby is on therapeutic hypothermia. Do we hold feeds fully? So you mentioned in the very beginning about the importance of priming the gut and keeping it going, because the gut isn't really ready when it comes, and we want to do our best to make it ready to face the challenges. And trophic feeds does just that. It makes it ready to progress quickly when we are actually ready to progress. So if a baby is really unwell and you're worried, you can hold the progress part, but the 10 to 20 ml per kilo that we give as trophic feeds, which is basically to maintain the gut's priming function, to keep it ready to take go to the next step, is what we need to do, and try not to hold back. And in the beginning, we do encourage strongly about breast milk, but if you don't have much of express milk to feed, using the breast milk for mouth care of these babies. So oral application of the colostrum is going to be very helpful if you get few drops. I mean, you may not be able to put it down the tube because it will stick to the tube, but you can use the milk into the mouth of the baby, just rub it in, and that is shown to be beneficial as well till you get more volume.
So again, to expand on what you were saying about the trophic feed. So trophic feeds is really considered anything less than, like you said, less than 25 mLs per kilo. Really, it's kind of 10 to 20 mLs per kilo. And really the definition of that is that you are providing this not to really benefit the baby nutritionally. In fact, when a baby is on trophic feeds, I don't really even account for those calories or proteins or whatever. But really, exactly like Dr. Sridhar was saying, that you are just priming the gut. And even oral care is even kind of like a smaller version of that. As you all know, breast milk has all these unbelievably amazing qualities to it, not nutritionally necessarily, but all the good enzymes, all the good bacteria, like we keep saying, which, are basically probiotic bacteria. You're hoping they're going to end up being commensal bacteria, all the immune functions, all of those things are really good, even with a few drops getting them into the mouth. So even a really, really sick baby, and now we're talking babies on inotrope. So if they're on dopamine or whatever, if they're being cooled, if you're a term baby, if you are a tiny preemie baby, really any baby that you haven't decided needs 100% gut rest should probably be getting some level of trophic feeds, even if that is 10 mLs per kilo per day.
Yeah, one very important point here is about encouraging the mother to start expressing. But the time of starting expressing within the first hour has been shown to be beneficial. You still have to start within the first hour of birth, and the team has to function together, the obstetric team, the midwives, everyone has to function together in having this as a goal, that the expressing of milk starts within the first hour, because it's definitely shown to that first hour after delivery greatly increases output. We often see mothers struggling to get even a few drops even after a couple of days. It does happen with the stress and everything else, but speaking to her before the delivery, making her aware that this is important to start, the importance of breast milk for these babies. Even if she wasn't planning to breastfeed, we still have to encourage them, because the premature babies, the breast milk is really gold.
Yeah, so I will also say that, adding to that, it's really kind of almost reassuring for mothers. It's very difficult for them after they've had their baby. Often it's a surgery, often they're magged out. It's really nice giving them this big role that this is something that really, really helps their baby. It's very easy for them to feel kind of useless. The baby is away from them in an isolate. Normally we're in a low stimulation for the first 3 days, so they're not even holding or touching or anything. So putting this emphasis on them that this is the best medicine that we can give, and get pumping, without obviously putting too much pressure on the mummies. If they can't produce the milk, they can't. It gives them a goal to work towards and kind of involves them in helping us to take care of these babies.
Yeah, in terms of trophic feed, the volume we mentioned 10 to 20 ml. Some units start with 4 hourly or 6 hourly, but you don't really need to do that unless you are really worried. It's a very, very tiny baby, less than 500 gram, and you're very worried. You can go for a 4 hourly distribution of this volume, but the volume is very limited. Even if you go for 2 or 3 hourly, it's fine. And you're not going to progress till you're comfortable, but the aim is to progress as quickly as we can. So the earliest opportunity, it may be the next day. So you start trophic feeds today and you think the baby is ready to progress. So the advantage of starting early and progressing early is that you have less days on TPN. You have, if EBM is available, if it's a 28-weeker and above, probably you're going to start progressing the next day. But in a baby of 27 weeks and below, you probably wait 3 to 4 days. So get the opportunity, progress cautiously to start with if you have risk factors. But once you know the baby is tolerating, you'll go faster. So do you want to give an idea of the progression?
Yes, very similar to that, actually. But really, I do want to emphasize that what everybody should be doing in your unit is the same thing as everybody else is doing in the unit. So standardized advancement of feeds is so important. It really has been shown to decrease the incidence of neck in the unit. So as I think we've talked about this already, and we've all discovered this over the past few years, that 22 and 23 weekers, especially 22 and early 23 weekers, are kind of a different beast. I mean, you can tell from their very gelatinous skin. Most likely their intestines are kind of that gelatinous and skinny as well. And so these are really the babies that we do end up, especially less than 500 grams. We are doing the trophic feeds for kind of 3-4 days. We'll start with, 1 ml Q6 hours is basically 10-15 mLs per kilo. And so we start those really, really slowly. And those babies are babies that we're probably going to need a PICC line in. The older kids, if they're 27, 28 weeks, our protocol is to advance those a little bit faster. And if we can get by with just the, 7 days of the UVC and maybe a couple of days of PIV without even having to put a PICC line in, then that's great. Generally, all our babies, once we'd started advancing them, we pretty much advanced them 20 mLs per kilo. The bigger babies, kind of above 30 weeks, we're advancing them 30 mLs per kilo. But that is very clearly written out in our protocols in our unit. And that is what we are all following. So let's talk. I know this is a very tough topic. Let's talk a few minutes about residuals. What do you do about residuals in your unit? Are your nurses checking them?
Actually, there are two sides to it. One is checking the stomach contents to confirm the tube position. So it's now safety rules that you need to make sure the tube is in the stomach. We have the pH paper. Nobody pushes air anymore. And if you have a doubt, you have to position the baby to the left lateral position, check the aspirates again. And obviously, there are different steps to do. So you are checking if the tube is in the stomach, you are getting it. But the difference between checking the tube position and checking for residuals is that for residuals, you really are drawing everything out of the stomach. So you are sucking harder, sucking longer, and removing all the contents. So basically, if you can encourage your team to avoid checking residuals, just check the tube position unless there is distension or reason for concerns. That's a best practice. So over the past year or two, we have managed to at least reduce it significantly. But in this area, we don't have a total consensus. The nursing opinions have to be respected as well. They've been doing it for such a long time. So one thing we can stress here is that use the lowest suction level possible and don't keep pulling. Don't hurt the mucosa in the process, because you do get some blood-stained aspirates just because we are checking for residuals as well. But if you do check for residuals, the message is that you should look at the percentage of total milk volume you're giving over that period. Avoid holding feeds overnight just because you're on a night duty alone without the consultant with you, because you're wasting a huge lot of time. Every day matters, every feed that you hold matters. Think sensibly, is it really going to be a concern? And if it keeps happening for a particular baby and you feel baby is really good, stop checking for residuals, at least for that baby. What would you say about that?
Exactly what you're saying. I think that happens a lot when we're cross-covering, when we're all cross-covering. The easiest thing to do is the safest thing is always to do, like in the short term, stop the feeds because you're worried that this baby's not tolerating it. Is this baby developing neck? Kind of unlikely. So how much damage are you doing by letting that milk sit in the stomach if you're not actually actively worried about neck? Same thing with lots of other things. Babies having a couple of A's and B's, the easiest thing to do is intubate the baby. I mean, it's easier to do a septic screen and start antibiotics. In the long run, if you're doing this on every single baby, it's not good for the outcomes. It's not good for your unit. Like you were saying, every single time we check residuals, they're a little bit elevated, we stop feeds, we're getting really far behind with nutrition, especially since you write your TPN at the beginning of the day and you're probably not going to be making up the rest of that nutrition if you are holding the feeds and just kind of teeing in something. So really that's the argument against checking residuals, that we all jump on it way too quickly. We're like, oh, this baby's got a 50% residual, oh, let's go do something about it. And that ends up stopping feeds, maybe getting a KUB, keeping them NPO overnight, all not good things for their future. So the argument is that really we shouldn't be doing anything about residuals. But if somebody calls you and says the abdomen is big, or this looks different, or this baby's lethargic, at that point, maybe you check with residuals and you see, okay, on top of that, are we not tolerating feeds? But just kind of the routine checking of the residuals, really, there's a lot of arguments against it. I've said this before, though. I think if I was at the bedside and my baby was acting up in any way, like baby vomited or spat up a couple of times, I think if I were a nurse for like 30 years, I think I'd find it really hard not to be like, I wonder what the residuals are. So I think it is a difficult kind of blanket statement to say, never check residuals. The
nature of the residuals is important as well. And obviously, one of the commonest reasons we get green residuals is because the tube is too far in, more than the baby. So always double check the feeding tube is in the right place. You may have to pull it back a bit because it has crossed the pylorus. Whenever we want to put a transpyloric tube, it doesn't go, but it goes spontaneously more often than that. So
I always think that.
So it's funny.
I know. I always think that. Do you do transpyloric feeds in your unit?
Actually, we have very selected cases we have considered, but to be honest, as we said, spontaneously it passes more easily than in the case you want to. The surgeon has advised to put in a longer segment in, but I mean, when we need it, it doesn't really work. Have you tried it? Yeah, I mean, we do it mostly in kind of older kids, chronic lung disease with really bad reflux and stuff. So we have discussed trophic feeds, we have discussed residuals, and we have discussed situations where we might go faster with the feeds or slower. The babies who are 32 weeks and above are obviously a different story, and we can go 30 to 40 ml per kilo per day, and we don't use TPN in these babies most of the time. Yeah. One unique group of babies is where we have growth restriction. We previously used to hold feeds for a few days or go slower with them if there is significant Doppler concerns, especially absent or reversed end-diastolic flow. Most of the units, if they are below the third centile especially, and they are below 34 weeks, we do tend to go to a high-risk feeding regime, which you described as 20 ml per kilo per day increment after a couple of days of trophic feeds. And then once they tolerate for a few days, at least reach half feeds, we can go up faster. So would you do the same? Yeah, we do. I mean, the thing is, I'm sure, as everybody's realized at the bedside with these IUGR babies, they just don't have great tolerance. It can take a really long time for those guts to start working. And so sometimes they're telling us that they don't want to go that fast. They're spitting up. They've got loads of residuals. They're constipated, IUGR, but especially a lot of these mothers are on magnesium. And so that just exacerbates everything. But I do feel like we try to push them. We're not as crazy as we used to be, like worried that we're putting too much stress by trying to advance IUGR babies. But I do feel like this is the population that is the hardest to feed at the beginning. They have the most residuals. They have, the most feeding intolerance. A lot of them are constipated. They don't want to poop. It takes a really long time for kind of peristalsis to get going. And that's even with the IUGR babies I've found not on magnesium. Yes. I don't know if you feel the same way. We have to be cautious with them, but cautious optimism, you can say, or progressively cautious. Don't be too held back, but if they're tolerating and giving the right signals, move on. But if they have signals which are not right, you have to be cautious. So before we close for today, I mean, Fortification is other important topic. I mean, we obviously want breast milk, and
Sure.
there is not enough breast milk. We do use premature formula, and if a baby is difficult to start tolerating the premature, we can use a term formula for 1 or 2 days. Nutritionally, the term formula is not optimal, so we do prefer the premature formula. And when we start using breast milk and we reach like 50 to 60 ml per kilo of breastfeeds, this is the time we start reducing the TPN, and the nutritional intake is going to reduce. So most of us agree that fortification is a way to go, and I don't want to enter the debate of human milk-based fortifiers because they're mostly out of the pocket range for most people, and the studies, the evidence is not really conclusive. We discuss probiotics in a separate topic as well, but in terms of fortification, what is your practice? I mean, do you follow a similar pattern?
Again, very, very important that this is standardized in your unit. That's kind of the key part of it. In our unit, we normally fortify at about 80 mLs per kilo. The tiny ones will actually go to 22 calories, like the kind of 23, 24 weekers. If they're slightly bigger, then we feel better going straight to 24 calories. But, you know, we're just all decided that we're going to go slower. Sometimes we feel like there's a big protein load with going straight up to the 24 calories if we're fortifying, you know, with a human milk fortifier. But really, again, all that's been shown is that just do the same thing as your unit. You can argue that you should fortify from the beginning. You should argue that you fortify when you get to full volume feeds. But like really, the important thing is I think that everybody's doing the same thing.
That's good. I mean, do you use human-based fortifiers or?
We actually don't. Yes. Most of the time, the only times that we will use it is if we really are not tolerating the human milk fortifier. I don't really want to get too far into this, but we have found kind of more consistent, better growth when we're giving calories with the formula fortifications rather than the human milk fortifications. Yes, obviously, there's lots of things that you can play around with the human milk fortifiers, but and again, going back to the fact that we've been, you know, have very low rates of neck in our unit that we're very happy with as well.
Exactly. There are so many factors that play a role in EC. And I mean, one point I would like to make here is that there are some mothers where I don't know if you face it in US, but in the developing world, certainly the protein content of the breast milk is very variable. There are some mothers where the EBM with fortifier doesn't have enough protein. So we may have protein supplements, but where we don't have protein supplements separate, in some cases, I do 1/3 of the feed as preterm formula just to standardize the protein intake, and it does help. And most of these babies are in a catabolic state and when they are low in protein. And once we supplement for a few days, even with the same previous dose of breast milk, they would start gaining weight. So just to bring out of that growth dip, and then they start gaining better even with the previous feed. You don't need to continue the formula if you have enough breast milk. And before we close, just one final point on the feed frequency. I mean, most of us use 2 hourly feeds in the NICU in sick babies on breathing support.
Q3. We do Q3 hour feeds. And that's, I would say, a lot of America. Most units I've been to in America are doing Q3 hour feeds.
Once they are stable, we do 3 hourly. But when they're on respiratory support, for example, we prefer the 2 hourly. I mean, reflux, whether we agree or not, does play a role in the sick babies in the acute phase. And having a smaller volume in the stomach is one of the easiest steps. Of course, in UK, when I used to work 10-15 years ago, hourly feeds were quite common in the tiny babies. Then we realized you don't really need to do hourly feeds, and 2 hourly is tolerated. But between 2 and 3 hourly, I do find a difference in terms.
I've also heard in the UK, they don't really fortify feeds, right? They just go up to like 80. Oh, they do. Okay. I thought that it was more like going up on a much higher volume rather than the fortification.
No, nowadays, I mean, most of us don't go beyond 160. 180 is a stretch in most cases. So.
And then what's kind of the highest calories that you'll go to? Like, obviously, we said we go pretty routinely to 24, but a lot of time on these babies, we're going up to higher fortification of the breast milk.
They tolerate. I mean, 24 is usually the upper limit for the premature formula. What we have is what you'd get with the breast milk with the full strength fortifier. But additional protein supplement can be considered. And if you are adding that, obviously the calorie intake would go up a little more. The osmolarity would go up as well. So you have to be careful about the medications you add. The compatibility, osmolarity of it, especially if you have calcium and phosphorus, don't give them at the same time.
In a lot of the states, I agree, calcium and phosphorus have ridiculously high osmolarity. I will really try to avoid those unless the bones look horrible on x-ray. The alk phos is like way above 1,000 because a lot of it isn't even absorbed.
Especially
So obviously there are
month,
times, but here we have the human milk fortifiers, which are specially made, exactly the right proteins, calories, calcium, phosphorus that we're adding to the breast milk, small vials. Babies can't go home on them, so we have to switch them over to a formula before they go home. But we can take those up really pretty easily up to 28 calories per ounce.
Bone health is better with these. The bone health is better as well because they have the calcium phosphorus supplemented, and we don't see the hyponatremia as well.
Yeah, exactly. And just one last thing that I wanted to say, that, going back to what you were saying about encouraging mothers getting breast milk, in a lot of units in America, we do have bank donor breast milk, and we can get it. But even though the mothers that are donating this breast milk are absolute heroes, and we are so thankful for you, and it is an amazing job that you are doing. You are saving thousands of babies' lives by donating your breast milk. Generally, the mothers that are donating it, though, they're producing a lot of this breast milk, or the babies are much older that they've had their babies when they're giving the breast milk. So definitely it's not necessarily very nutritionally complete. And a lot of those babies do end up with, like you said, they can have slightly lower protein in the breast milk, the donor breast milk, as well as even lower electrolytes. And a lot of our babies on donor breast milk will become hyponatremic just because it really isn't as concentrated. So thank you so much for everybody that's getting the donor breast milk, but also be aware if you work in the unit.
Even the mothers who work hard when they are stressed themselves, I know it's their natural role, but it's
so stressful. It really is.
That's good. I think we had an amazing session, and thank you for this nice discussion. I hope the audience and the colleagues who are watching this would be able to feedback their unit practices. There are always going to be subtle differences, like we discussed the difference between 2 and 3 hourly and how you get used to a certain pattern. You start believing in a certain thing and you stick with that, but whether it is really right, I mean, these are things which is very difficult to prove by evidence-based studies, because in a particular baby, it may make a difference, but when you plan a study for a bigger group, it's hard to show a difference. But as long as it doesn't change the workload pattern of the nurses significantly. So the only controversy we had is 2 or 3 hour day. We'll leave it to the audience to decide what they do. So with that, we will wind up today. Thank you. We will meet up soon, maybe in equally challenging topic, which is clinically important as well. Thank you.
Yeah. Thank you so much for all being here. Thank you.